Hey folks, Scott Weingart here, and this is the EMCrit podcast. Today, who to refer for CV-ECMO, how long to wait, what to do in the interim, how to make it happen. Whether it's calling your own folks at your shop if you're a major referral center, or if you're in the community or a smaller center, how to call another hospital for CV-ECMO referral. But really what you're going to take as the message today is, first of all, call earlier. Don't wait until they're already at the entrance to the death spiral. And that maybe you shouldn't just be calling at the point for ECMO referral. Maybe we should start thinking about this as a paradigm for referral to respiratory failure centers. But you'll hear all of that with my colleague and partner in crime for all things cardiovascular EMCrit, Trina Augustin. And everyone, if you have any contact with Trina, congratulate her. She has just gotten a spot for next year at the Mayo doing cardiovascular critical care and emergency medicine. Basically like the perfect spot for her. She's going to be helping start the ECMO program there. It's just going to be amazing. So you're going to be hearing even more incredible stuff from Trina in the coming months and years. But I think you're really going to enjoy this. I think there'll be a lot of commentary. So go to the episode, emcrit.org/343, and put your comments there. Tell us what we got wrong and right. And we will always give the proviso for all things CV-EMCrit. Before you say we missed this, read the post, because we can only do a portion of the information on the podcast, and we really put all of it. I mean, Trina does an amazing job writing up these show notes for these episodes to make sure that everything that could possibly be covered that we have thought about is actually there in the show notes. All right, let's roll right in. But of course, you know, we're not actually going to roll right in because you're listening to the free version of this podcast, which means you're not an EMCrit member, which means you're missing out on the information that will allow you to take care of your critically ill patients in the best fashion possible. You don't have time to read 60 journals on resuscitation and acute critical care. You don't have time to vet the latest information with experts in the field on a constant basis to see what actually pans out and what doesn't. But what you do have time to do is listen to the EMCrit podcast, get the updates, get the literature reviews that you do not get unless you are an EMCrit member, get all of the episodes, not just the ones that we decide to make foam. And we make a lot of foam, but we also make a lot of non-foam that you are missing out on. So if you really care about taking care of your critically ill patients in the absolute cutting edge fashion, then you should just go to emcrit.org/join. That's emcrit.org/join and become a member. Super cheap, get CME, write it off on your taxes, all the good stuff. Okay, now let's really roll into the show.
So today we are talking about one of my favorite topics. When I first talked to you about starting the CV-EMCrit, I was talking about my love for mechanical circulatory support, ECMO. So I am delighted to be talking about VV-ECMO, and specifically a topic that's near and dear to my heart as being part of an ECMO program, and specifically a mobile ECMO rescue unit, is patient selection and when do we call for help?
Yeah, it's perfect because people might get scared off when they see this. They're like, I'm never going to be doing ECMO. Yeah, that's not it. Everyone needs to know when to refer for ECMO and how to do that at the optimal time and in the optimal fashion. That's what we're going to talk about today. So where should we get started? What is the first and
This topic is something that I think a lot of us are thinking more about right now. I was watching the news the other day and I saw them flash up that kind of triple pandemic. And I realized that that's something everyone's fearing, this hit of RSV, influenza, and COVID. And I was thinking, we have seen this kind of uptick of ECMO with the COVID pandemic, but are we going to see way more of it this winter? And if so, for people who specifically work at these centers that don't have ECMO, when should they be thinking we should call? So I think we should jump in with, first of all, talking about kind of the main 5 things that I think about with kind of an ECMO referral. And I can go through and just list them, and then we can chat about each one in detail if that works.
Let's do it. Go for it.
All right. Perfect. So first and foremost, is your patient in acute respiratory failure? And then second, is this a reversible condition? Is this something that is easily treatable? 3, have they failed conventional treatment for this? 4, is there a lack of or absolute contraindications? And 5, are we early in that disease process and are you referring early? So those are the big topics that I like to attack when I think of this topic.
I love it. All right, let's go one by one. So let's talk about the degree of respiratory failure that would make a ECMO referral a good idea.
Awesome. So I think if you look at different literature, you're going to see different definitions. The EOLIA criteria is some that a lot of people reference. The most common of those criteria that we look at is this P to F ratio of less than 80 for greater than 6 hours. Normally, they're talking on being on a high level FiO2 at that point and at least a PEEP of 10. You'll also see them reference having a pH of less than 7.25 with a PCO2 of greater than 60 while attempting to maintain plateau pressures of less than 32. Most of us who cannulate for ECMO are going to tell you that we want to know about the patients before they meet these criteria, but these are just rough criteria to use and that I think are useful to think about.
Yeah, absolutely. And you said this perfectly, but just to clarify the audience, you don't need both. It's either an oxygenation or a respiratory ventilatory failure. Now, you could have those coincident, and let's be honest, most of the patients referred are for oxygenation issues. I don't see the severe asthma that would get me a VV ECMO referral very much anymore, if at all. What about you folks down in Emory?
Sadly, we are. I would say we probably still are cannulating a couple a year, but the great thing about those, and we can get to that in the post, is they do really well. But unfortunately, we still see them occasionally. I think it's much less frequent now that we have such great colleagues who are working with primary care, and these patients are being caught early in their disease progression, and we're preventing these severe exacerbations. But it is something that still occurs.
All right.
And I have a referral bias. Truly, we are a large referral center and we cover a large catchment area. So I'm going to see more than most people will see.
All right. But most of the people are going to be getting these referrals because of inability to oxygenate despite conventional ventilation. All right. So That's step one. What do you think about the Murray score? I know that's what we used when I trained at shock trauma. We're more of a Gestalt situation right now. What's your take on that?
So I think the Murray scale, that some programs use it a lot. It was something that we never used as much here. And I think that kind of speaks to also some of these other prediction scores, like the RESP score, the PRESERVE score. And I think actually potentially the RESP score is the one that I've seen people use the most. And for people who aren't familiar with that, it's this respiratory prediction and ECMO survival score, where basically they are taking into account a patient's age, their acute etiology for why they are needing ECMO. They're looking at, are they immunocompromised? How long have they been ventilated? Do they have a devastating neurological injury? Have they had a cardiac arrest? Do they have elevated peak pressures, elevated PCO2? Are they requiring a bicarbonate infusion? Basically, all of these different factors, and are looking at if these patients have a more negative score, this has been linked to a decreased in-hospital survival. Like any other prediction score, unfortunately, it doesn't quite tell the whole story. Most of these prediction scores are looking at patients, maybe not the Murray score, but most of the others are looking at patients that they derived these scores from like a retrospective cohort that were all already cannulated for ECMO. So right there already, there's this limited generalizability to your population that has not yet been cannulated. Two, at best, they have moderate discrimination between survival and non-survival. And really, as all prediction scores, you're looking at a population level rather than that individual patient in front of you and taking into account kind of the nuances that go into these. They are great scores. I find that they are most used in combination with a multidisciplinary team approach. Look at the specific patient, their acute clinical condition, their comorbidities, and why they have this respiratory failure.
All right. I love it. Do we need to say anything else on that first point of respiratory failure sufficient enough to call for ECMO?
No, I think that's great. The one thing I would say is if you're someone who's listening to this, definitely go to the post and look, and there are links to these scores because this is something to be very familiar with, especially if you are someone who's constantly referring patients to a center. It's good to know these scores too.
Yeah, we'll say for CV-EMCrit in general, if you're going to write us a nasty letter, please make sure you've actually read the post prior to saying we did not cover something. All right. Step 2, is the respiratory failure reversible?
Yeah. And I like to do this by looking at two extremes. I think intuitively it all makes sense to us that things like an acute asthma exacerbation or that postoperative patient that has that acute negative pressure pulmonary edema, those are quick onset. They're very treatable. They're rapidly reversible. That makes sense. The other extreme is that patient with that interstitial lung disease that's unfortunately not a candidate for lung transplant. I think those extremes are like the good example of you can see that those patients that have this rapidly reversible reversible, very treatable disease are great candidates. And in between in there are probably the more common patients that we're cannulating for. These are the patients with your aspiration pneumonitis that's really bad, or viral or bacterial pneumonias, which is incredibly relevant to this season right now. And most of these patients can do really well. ECMO can buy them that time to allow for recovery and treatment.
Yeah. In the ECMO world, this means they need a bridge to somewhere. And so
Absolutely.
if there's a bridge to liberation, great. If there's a bridge to transplant, great. But if there's a bridge to being on ECMO for the rest of their life, we're not going to think that's a great idea.
So true.
All right. So then step 3 is the respiratory failure refractory to conventional management.
And that is going to depend on what's the etiology for respiratory failure. By far and most common reason we are cannulating people is for, as you mentioned, hypoxic respiratory failure and specifically ARDS. And so with these patients, are they refractory to lung protective ventilation, to proning? Have you optimized their volume status? Have you considered paralytics and inhaled therapies? Not that you definitively need to trial this on every patient, but have you optimized the ARDS care? On the other hand, if it's something that you're referring to for a difficult airway, it's very different. Is this someone with a failed airway attempt in the setting of either an anatomically difficult airway or someone that has massive pulmonary hemorrhage or pulmonary edema? Basically, have you exhausted or do you anticipate exhausting the normal treatment methods? For someone that's in an anatomical difficult airway, this might be someone that we're placing placeholder lines in and we anticipate this airway is going to go wrong and we want to know about them early. So definitely don't wait until the airway has failed if possible.
Yeah, absolutely. This is the one that for me is the most nuanced and the most representative of what a good referral center could do, or the home institution even. My problem with this is that many patients we had referred to us for VV-ECMO at day 6, we look at the chart and say we could have, and we're guessing, you can't turn back time, but we could have avoided this. We're getting referrals from outside centers that just were not as aggressive with the implementation of aggressive treatment for ARDS. The patient wasn't prone until way into their course. They never achieved the degree of recruiting lung settings that I would personally have placed the patient on. And unfortunately, by that point, yeah, they meet the 7-day arbitrary limit, and we'll talk about that at 0.5, but they were pretty far gone. Their lungs have taken an enormous hit when most of the patients, I think, in an aggressive center would have been optimized on day 1 and 2 and avoided this whole thing. And further that, my mentor for all things respiratory and ECMO, Nader Habashi at Shock Trauma, was brought there to start a VV-ECMO program. That's what he was brought there. And I think for his first few years, they cannulated like one patient because all of them were amenable to just reversal by aggressive treatment with things like APRV or whatever advanced ventilatory modes you want to use. So how do we reconcile that? And what does that change for our referral pattern if you had your ideal world?
I love that you're asking that because this is something that I think about on about 50% of the referrals we get. Rapidly escalating treatment and being super aggressive with the care early on is imperative. And I think we'll probably discuss this more, but more and more of the limited studies we have are showing that early referral, these patients have so much better outcomes. And truly, to be able to refer early, 1, you're anticipating their trajectory, but 2, you are actively implementing that. These are patients that are getting proned right away. These are patients that you are optimizing their volume status right away. This is definitely something that needs to be paid attention and something that I love this because everybody can do this. It doesn't matter what center you're at. You really can do aggressive upfront care for these ARDS patients. And it is imperative. I argue that it is probably more important than the skill of the ECMO cannulation and our management because you can really make a difference upfront. And 1, you can avoid the need for VV-ECMO on many patients. But for those who do need it, you can get us in that time frame where we can be cannulating early. So this cannot be stressed enough.
Yeah, I think you've hit it perfectly. I wish we would stop calling it ECMO referral centers and they became respiratory failure referral centers. And we have evidence for what you and I have just said. The Caesar trial showed this. Most of the patients referred who were at the point of the study demonstrating the need for ECMO were not put on ECMO and had a good outcome without it. It's there. If you're a smaller center, there's no shame in, if you haven't proned a patient in 3 years, you probably shouldn't be proning and then deciding to make an ECMO referral. It should simply be refer at the point you're considering proning, maybe prone them, but get them the hell out of there. Is there anything else we should say about is there anything we should talk about for the type 2 respiratory failure in terms of did they optimize or not? What is your referral stop point for that, at which point they failed conventional mode for CO2 issues?
Yeah, I think that this is difficult. And really, thankfully, this is the minority of referrals. It's rarely that type 2 respiratory failure is the primary problem. I think the biggest thing is making sure that you are doing your best to ventilate them safely. We're seeing more and more patients come in with significant barotrauma. And while per ELSA, that is a reason to cannulate, I will say, especially in the COVID population, when we see significant barotrauma with pneumothoraces and chest tubes in, we're seeing more of these patients not doing well. In fact, increased mortality. And I know personally we've been seeing that, but I've also seen in the literature that's also been expressed. So I think doing your best, that if you are having difficulties optimizing these patients, conventional methods, calling early, sure, you can put on the bicarb drip and do all of those things. But when you're getting to that point, you are at a bad spot. So definitely be reaching out early.
There you go. All right. Step 4. This is the controversial one. Are there contraindications?
I love this because this is, I think, where the nuances lie. And these contraindications tend to be an evolving topic. Per ELSA, the kind of only absolute contraindication is disease expected non-recovery with no viable decannulation options, i.e., think of that patient with end-stage COPD or interstitial lung disease that's not a transplant candidate. I think to most of us, that's clearly a contraindication. And it's definitely to those of us who cannulate, because there is nothing more awful than cannulating a patient and having a bridge to nowhere, and then having that difficult family conversation and saying, I know your loved one is awake and talking to us, and we had them extubated, but there's nothing we can do. We're going to have to remove care. You're going to have to tell us the time of death, like when you want this to happen. I think that's the one kind of black and white situation. Unfortunately, most of the rest there's a lot of gray areas. So I think the best way to do this is take one at a time and kind of talk about kind of these relative contraindications. If you're someone who likes to look at the prediction scores, you're going to see a fair amount of these listed, especially in the RESP score.
All right, let's go.
Let's do it.
All right. So you got older age down there.
Yeah. So I think that this is one of the first ones that comes up on almost all the literature that you look at. I will say that the cutoff is somewhat arbitrary, or very arbitrary. Most people will use a cutoff of 65 to 75. And I will say that during the height of the pandemic, when resources were tight, you saw the age limit even being pushed lower. I think the thought is with advanced age, there's often increased comorbidities, there's less physiological reserve, and there's definitely a link to decreased survival. Now, at the same time, as someone who cannulates these patients, I'll tell you that the 67-year-old marathoner that has limited comorbidities may do way better than someone younger with extensive comorbidities. And that's where, once again, the prediction scores can fail us, because you do really need to look at the person. But as an overall gist, the older age, unfortunately, the worse people tend to do.
Yeah, absolutely. And it's just as you say, it's physiologic age, not chronological age. So that should there should be some allowances for that. But then they also, just by the nature of the game, have less quality adjusted life years to gain. It's not discrimination. They do worse. There's definitely been associations with older age and outcomes. There's usually going to be some relative cutoff at every program. And it's funny, at the Sharp place where Joe and Zach, my buddies in the ECMO world, are, the age keeps creeping up as the director of the program keeps getting older, because as you can imagine, you don't want to age yourself out of that possibility. So maybe that's what you need. Maybe you just need Victorian ECMO directors. All right. CNS hemorrhage and significant CNS dysfunction.
Yeah, so I think that this is another one that's pretty distinctly listed out in the literature. And there is some kind of gradation of this. Someone with an intracranial hemorrhage or a significant stroke, just recurrent seizures, patients that are obviously clearly not great candidates. But there is a murky area here where you have that encephalopathic patient, and maybe this is just encephalopathy secondary to sepsis or something that's potentially reversible, but you don't know that. So it does become a little nuanced. What I will say is the concern is that you are going to cannulate this patient with their respiratory failure, and that even if you have recovery and improvement that you can decannulate this, what we don't want to do is cannulate a patient that has a devastating neurological injury or dysfunction that unfortunately they will not have a great quality of life. So that is a big thing that we always look into. And my biggest fear is always that I'll cannulate that patient and they don't wake up on ECMO, and I end up scanning them and there's either loss of gray-white matter differentiation and they've had an anoxic brain injury from a code I didn't know about, or they had this massive stroke or hemorrhage. So we do really want to try to avoid that.
Yeah, let's just point out that also the hidden elephant in the room that goes along with everything you're saying, which is I am a proponent of eCPR because our runs are short and the hospitals make money and everyone is happy. VV ECMO is, even though the billing up front is very high, is usually a money loser for the hospital. The duration of care is just such that you burn through the initial payment, and then it's just on the hospital's dime for a lot of money. And these patients often are taking up beds that would be operative post-op beds as opposed to standard MICU beds. There's real problems to leaving a patient on for 4 weeks and then having a devastating neurological outcome. So I don't fault people for being very selective. And if you're going to invest the resources in this, wanting the patients to do well. We want that for them, but we also want it to make this a worthwhile therapy. What do you have to say about that, Trina?
Cannot agree more. There is nothing that will make your surgeons more angry than tying up that last cardio help system for 6 months on a patient that unfortunately does not survive. So definitely something that you need to consider closely when you are going to cannulate a patient.
All right, contraindications to anticoagulation.
Yeah, so I like this one because I think that this is definitely has been an evolving kind of target. For those of you who are involved in ECMO programs, you're probably going to be aware of this already, but more and more, we are seeing that many patients can actually be on ECMO without anticoagulation. And here I am specifically referring more so to the VV ECMO population. We see it more in our trauma population or other people that we have put on that unfortunately do not tolerate the anticoagulation. With our heparin bonded circuits, a lot of these patients can do okay. At the same time, you can't be an ECMO center and do this without knowing that there are some patients that will end up trying to clot off their circuit all the time. And it's really hard to predict those patients before you put them on. So I put this in as a relative contraindication because I wouldn't want a patient not referred specifically just because there's a concern that they could not tolerate anticoagulation. I think it would be a discussion that would really need to talk about risks versus benefits with the patient or their medical decision maker and as a team in whole to decide where does this patient fall on risk versus benefits.
Yeah, that's perfect. I like that. We could just leave that there. Immunosuppression.
So here again, this is one that when you look at the REST score, if you have immunosuppression, automatically they link you to decreased survival. And it definitely, in the limited studies we have, is linked to decreased survival. But what I will say is not all etiologies of immunosuppression are created equal. There is a trend towards worse survival with patients who have metastatic cancer, some of these oncological emergencies, and even patients with a solid liver or organ transplant that are immunosuppression versus that patient that might have autoimmune disease, HIV. Some of them actually have links to even if their survival is not as poor as some of the others. So just realize that depending on the etiology of the patient's immunosuppression, survival can be variable.
Prolonged mechanical ventilation. This is the one that I'm always interested in because I had mentioned earlier, I'd love these patients to be referred very early in their course. I'd love all the ECMO referrals to happen at the 48-hour mark, maybe even sooner when they're veering towards it because I'd like to get those over to the respiratory failure center and then we could see rather than waiting till day 6. So what do you have to say about the prolonged mechanical ventilation?
Agree. In fact, I'm at a center that we like to do awake ECMO cannulations. So we like to catch a lot of these even before they're intubated to begin with. And that's a nuance depending on what you're putting them on ECMO for. But yes, so I think that this is a hot topic right now. And with the COVID era, we have had a little bit more data, and obviously there's more data evolving right now. But many people consider that that magical 7-day cutoff where, really there's showing that there's better survival with less than that. And when you get over 7 days, there does seem to be an increase in mortality. In the COVID population specifically, there's some people who pushed even towards lengthening it to 10 days. Overall, I will say that the data that we do have does look like the longer someone is on ECMO, the longer that someone is on mechanical ventilation, the worse their survival is. Now, I think that there's some question of, is it just the duration or is it the lung injurious settings they're on? Is this if they have elevated plateau pressures? Even more controversial is if there's elevated driving pressures, barotrauma, like what exactly is going to increase their risk? And this is definitely an evolving topic. I think most experts, though, overall will say increased duration of positive pressure ventilation is probably, unfortunately, going to be linked to worse outcomes. So yeah, we want these people early. Within 48 hours is wonderful and ideal, but definitely less than 7 days if possible.
All right. Now you have cardiogenic shock down here. While that's not a contraindication to ECMO, it might not be an ideal choice for VV. So what do you have to say about that?
Yeah, so that's listed there specifically because I'm looking at focusing on VV or respiratory ECMO on this post. And when I put cardiogenic shock there, one of the things I was referring to mostly was LV predominant cardiogenic shock. Those are patients that you should probably be, if they're needing ECMO, they're going to probably need VA ECMO or a version of VAV ECMO. So not a great candidate for respiratory ECMO. Now, I say that to say, there are some patients that have RV predominant shock that might still be a great candidate. As you and I know, about 25% of patients that develop ARDS end up with RV dysfunction or RV failure. The setting of hypoxia, hypercarbia, acidosis is that like perfect storm for increased pulmonary vascular resistance. And suddenly your RV that's used to seeing a low pressure system and very little afterload has this insurmountable afterload and it fails. So there's some of these patients that with just this even indirect RV support, by decreasing that hypoxia, that hypercarbia, that acidosis, you decrease their afterload, you increase O2 delivery, and they end up with better RV function and you can actually have recovery. And there's even some of them that have more severe RV failure. You may need to consider a version of VV ECMO where you can do a dual lumen cannula in their IJ, like a Protect Duo, where you can actually provide more direct RV support. You're draining the RA, you are actually having your return port into the pulmonary artery, and you can provide that direct support with your VV ECMO. But those are definitely patients that can do really well with this therapy.
Yeah, that's a fantastic distinction. All right, multi-organ failure.
Yeah, so I love this. And maybe this is just because I so often sit there and I'm getting these referrer calls and I'm, what are we doing? So I think it makes sense intuitively to all of us that if a patient has multi-organ failure, or if you're someone who loves the SOFA score, a really elevated SOFA score, their lactate is super elevated, they're on 3 pressors. I think intuitively, most of us know this patient at this point, unfortunately, is probably not early in their journey. If it's someone that came in with respiratory failure and is now at that point that we have multi-organ failure, most of these patients will not do well. Here again, it's going to be patient specific. And maybe if you are a super young patient and this is severe hypoxia that has driven them into kind of this rapid multi-organ failure, potentially they could do okay. But it is something that as a whole that I pause very quickly when I start seeing all of this and considering them for VV ECMO.
All right. The last one on the contraindication list here is obesity, but you have a strike through. So yeah, it's funny. I'll hear what you have to say and then I'll render my thoughts, but tell me what your thoughts are on obesity.
So I love this one because I remember, and maybe it was me as an initial really novice cannulator, my first question when they would call me and say, "Hey, Trina, I have one for you. We're going to be sending you 4 hours out for this," was, how big are they? What's their BMI? And initially you'd hear that BMI of 60 or 90 and you'd be like, no, done. And now that's not even, sure, I ask because I want to know, do I have to prep different equipment or what's going to happen? But what we've seen at our center, and it seems like more and more because it's definitely showing up in the literature, is this obesity paradox, where this population with increased BMI that has all these links to increased morbidity and mortality due to a lot of these other conditions that go with obesity are actually having surprisingly good survival. There is a lot of controversy as to why that is. And some people will say they'll have upregulation of IL-6, TNF alpha. Maybe there's some endotoxin neutralization by adipose tissue. My own personal take, and this is definitely still just hypothesis going, is some of these patients with morbid obesity, I think, have a big restrictive component to their failure, and they end up having respiratory failure with less severe parenchymal damage. And so some of them seem to actually do really well. Granted, a lot of them require prolonged runs, so that's something you need to know before doing this. But truly, I do not believe that obesity should be a contraindication anymore. What I will say is, it does make the cannulation process more difficult. It becomes sometimes a 2-man technique to even get the needle in, the wire in. It makes transport quite challenging. I will say that I do a little sweating, not just in the process, but thinking about it when I think about these patients, because getting them onto my mobile unit and not dislodging my cannulas or compressing the cannula and making sure I have adequate flows and adequate cannula sizes, it's challenging, but it is possible.
Yeah, I agree with every word you said. My contention is the reason this used to be a relative contraindication is that people weren't using ultrasound. And I know today a lot of the CT surgeons are doing cannulations without ultrasound, and doing a obese cannulation without an ultrasound is a real bear. A lot of times it's not even possible. So I think that's what it comes down to, because if we could see the vessels, we could get to them. If you're going blind in a morbidly obese patient, it really doesn't work out well. And I think that's really where it stems from. So I agree. It should not be an absolute contraindication by any stretch of the imagination. All right. Now, step 5 is always consider the referral early. We've been hitting that throughout the entire podcast. Is there anything additional you want to say on that?
I think just because it's such an important thing is just to remind the listeners again is optimize these patients early, aggressively optimizing them early and calling early. I love when people anticipate that trajectory. As a referral center, there's nothing that makes me more happy than getting that referral early. And, if I have a 4-hour commute and suddenly 6 hours later, when I'm even almost there, they're calling me and saying, actually, this patient is looking better. That's great. If they don't need ECMO, that's fine. But that is so much better than getting that call when this patient is on day 7 and you're like, oh, they would have been a great candidate. Now I'm really concerned that potentially they won't do well. So I will definitely say, feel free to call early. There's none of us that mind getting that early call and saying, actually, I think they're doing okay. I think we can just optimize them. And we maybe should still come get them and bring them to our center. And we might have more resources than you do. We're even happy to come get them and just support them, even if we don't need to put them on ECMO.
Yeah. And I think that brings up the last point I would talk about, which is centers like yours, and I think it's the right way to do it, will go to the sending hospital and cannulate there when necessary. Some patients can come by ALS transport, but it's a dicey situation. These patients are super tenuous, especially with the referrals that were not as early as you and I may like. I really feel that retrieving them there is the optimal way to do it. They're so much safer once they're on pump. What do you have to say about that?
I could not agree more. I will say that my least favorite referrals are those that we're questioning whether they need ECMO, and I end up having to go out and transfer them. That makes me a lot more anxious because I will say you're in a bad position if you're on the back of an ambulance on a 4-hour commute and they decide to decompensate and I'm having to cannulate them on the back of an ambulance. That's not a great spot to be in. My ideal is go there, put them on pump. And sometimes I have to stay and play for an hour or two. Some of these patients need a significant resuscitation. There's that period of instability as you go on pump that can happen, no matter how slowly you go on with your flows and support them. I do think that most of these patients, it's safer to cannulate them there. And I'm speaking specifically VV ECMO. I think that VA ECMO is a little bit of a different beast. And so I'm not going to weigh in on that right now. But specifically with VV ECMO, if you have the capabilities of doing remote cannulation, and I'm someone who is well supported with a fantastic perfusion team. So when I go out, I'm taking a perfusionist with me, and we are able to do most anything that you can do in a hospital. So that has been, I think, the safest way to transport most of these patients.
All right. Is there anything we've missed? And again, we'll refer people to the post for more complexity on everything we spoke about. Is there anything else you want to add before we say adieu?
Just a reminder to the audience that if you have a young patient with really limited comorbidities and acute onset of respiratory failure, call us early, call us always. Remember that elderly patient with a ton of comorbidities who's been on the vent for an extended period of time, there's probably less chance that they'll have a good outcome. And then always aggressively manage these patients early, optimize their care early, call us early. I would recommend that if you're someone who works in the emergency department or the ICU, know your nearest ECMO center, have their phone number on speed dial so that you have them available at any time.
Yeah, absolutely. And get their referral desires down and put that on a piece of paper, because when you need it, you don't want to be struggling to find a phone number or who you're supposed to call. Fantastic. All right, Trina, I can't thank you enough. Can't wait for the next one.
Thank you so much.
All right, folks, there you go. Again, questions or comments, go to EMCrit.org/343. This has been Scott Weingart for the EMCrit podcast saying bye-bye. Well, before I go, as always, I'll mention medicine coaching. That is my physician coaching business, though it's not really just for physicians. Any clinicians are welcome to apply. What I'll spotlight this month is my Getting Shit Done coaching clients. Some of my favorite stuff. It's how I really started down this road, is helping people with their productivity. Now, look, you might be like a full professor with like 15 research projects and a company you run. I could help you. I could help you organize that. But I could even help you if you're just a pit doc who just wants to come home and not deal with all the misery of forgetting that you needed to close down your sprinkler system and now your pipes have burst from the cold weather. All of the stuff that is the routine part of everyone's lives, whether they have a bustling career in 17 different fields, or if they're just doing emergency medicine or critical care and they just want to come home and have more time to relax with their family and not have to think about all this garbage on a constant basis that's making you miserable, I could help you get that under control. I could help you create a system to deal with your email, with your project and action planning, which could be something as complex as a corporate takeover, or something as simple as how to get all the crap done for my yearly taxes without having to think about it. You know, Easy stuff. And then we will work on your knowledge base and preventing tasks from having to be done again and again and reinventing the wheel every single year. All of that will make you have more free time and more relaxation to do the things you truly love. So come on over to emcrit.org/coaching. That's emcrit.org/coaching. And we'll see what we could do together.